Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. Today's episode discusses strategies for management of severe COVID-19, including clinical trial data on the use of antiviral therapy, dexamethasone, and other immunomodulators like JAK or IL-6 inhibitors. I'm joined by three expert faculty, Dr. Stephen Cantrill, a recently retired emergency medicine physician and medical director at Denver Health Medical Center, Dr. Gandhi, an infectious disease physician at Massachusetts General Hospital, and Dr. Payal Patel, system-wide director of antimicrobial stewardship at Intermountain Health. This episode is part of a larger educational program titled COVID Rounds, Clinical Case Discussions on Best Practices for Inpatient COVID-19 Management. For more information on our faculty, along with the link to the larger educational program, please click on the link in the show notes for this episode. Now here is Dr. Cantrill to start us off.
So let's start. Now, this is a 45-year-old woman who has a remote diagnosis of mediastinal lymphoma, who received rituximab-containing chemotherapy in the past, presents to your ED with fever, myalgias, cough, and other URI symptoms with of 2 days duration. Her vitals, as shown, blood pressure 90/56, heart rate 120, respiratory rate 22. Her temp is 39.2 orally, and her O2 saturation is 90% on 6 liters via nasal cannula. Her physical exam is remarkable for bilateral freckles in the lung exam. Her medications include EPOC, rituximab. Her last cycle was 1 year ago. Her vaccination status, she did receive 2 doses of the mRNA COVID-19 vaccine 3 years ago, no booster doses. She reportedly had COVID-19 approximately 2 years ago. She did do a home COVID-19 antigen test, which was positive. Now, what therapy would you recommend?
Yeah, thank you so much. So we're going to move on to thinking about treatment recommendations. And so once the patient is requiring supplemental O2 or they're satting below 94%, that's when steroids, dexamethasone comes into play, remdesivir, and then depending on whether they're presenting with elevated markers of inflammation, thinking about baricitinib or tocilizumab, going into remdesivir and some of the evidence behind why the guidelines can be a little bit different. And you may have differing internal guidelines in your hospital as well. So to talk through why that may be. So going back to 2020, this was the big adaptive trial done by NIAID, Act 1. This was a multi-center, placebo-controlled, adaptive, double-blind, randomized trial. They looked at adult patients and they did remdesivir versus placebo. And really the primary outcome was median recovery time. How quickly did someone get better when they had remdesivir versus placebo? And there seemed to be a 5-day difference when patients had remdesivir. And so early on, remdesivir was recommended really widely for these patients. And as, we continue to have more and more work, then there have been more and more gray area to what we see. In this group, looking at the subgroup analysis, the benefit of remdesivir was clearest in those with symptom duration that was less than 10 days and on supplemental oxygen, but not intubated. So again, thinking about how remdesivir works, the biological plausibility, remdesivir is stopping the virus from replicating. And if we know that earlier on in disease, that's when viral replication is at its highest, that is probably when you're going to have the best chance of remdesivir being helpful to the patient. So going back to the case, earlier the better. If you have a patient who's presenting, who's rapidly getting worse, that may be someone to think about remdesivir early. Solidarity was a large WHO trial done very early on. I think it's really interesting to think about, in March of 2020 or February 2020, as this was being put together, we really didn't know what was going to work. And so when this study initially started, it was actually to evaluate remdesivir, hydroxychloroquine, lopinavir, and interferon. And as more evidence came in, really remdesivir ended up being the main thing that this trial was looking at. So I think that's really important, putting in context where this trial came from. Initially, as the primary outcome that, in Solidarity showed that there wasn't actually a difference in in-hospital mortality rates for remdesivir. But looking into a subgroup analyses, it was found that the benefit for remdesivir is among patients who are not receiving mechanical ventilation at the time of enrollment, and that it showed a significant reduction in progression to ventilation in this group. So, there can really be some difficulty in understanding all of the literature that has come out. And the way that we put it at our hospital, we have a fact sheet trying to describe what the evidence has been, is that there's often discordance between clinical trials and then real world retrospective studies regarding the benefit of any initiation of remdesivir and those already receiving mechanical ventilation or ECMO. And that leads to that discrepancy in the guidelines that we talked about. I also wanted to share this study. I think this was really interesting. This was just in a CID last year in 2023. This is a retrospective study, so different than a randomized trial, but this was propensity matching in a large cohort. This is in the United States. And they looked at remdesivir for immunocompromised patients, similar to the case that we were talking about today. And when they looked through different variant waves, they actually found that early on, remdesivir within 2 days of hospital admission seemed to be associated with significant reductions in mortality, both at 14 and 28 days. I think, this study is important because often we lament that immunocompromised patients are often left out of different studies. And so I think this is really important. There is, when you look at the study, they did have to lump a number of immunocompromised patients together. So there might be, more work to be done in this space. But thinking about our case, remdesivir does seem like a good choice. Okay, I'm going to transition to Dr. Gandhi.
Thanks. As you put in the outset of the kind of continuum of COVID, inflammation really seems to be driving a lot of the disease when you get to a person like we're caring for, someone with severe shading into critical disease. So we're going to spend some time now talking about the role of immunomodulators. And let's start off with really the study that changed the way we treat COVID overnight, essentially in June 2020. This was the recovery study that was done in people with COVID-19. It was open label. It was randomized. It was done in individuals hospitalized with COVID-19, and they were randomized to get dexamethasone or to not receive dexamethasone. And what you're seeing here are some of the points that were made before. People on oxygen, people on mechanical ventilation had a substantially lower rate of mortality. So for mechanical ventilation, ECMO was a 36% lower rate of mortality, rate ratio of 0.64. And for those just on oxygen, not yet on mechanical ventilation, it was an 18% reduction in mortality. I want to reiterate the point that was made before, that in people hospitalized that were not on oxygen, there was actually a trend towards higher mortality. And certainly during the Delta wave in India and other places, I think some of the challenges were inappropriate use of steroids in people who didn't meet this indication of being severely ill. Now, the recovery study was followed soon thereafter by a meta-analysis of a number of different studies that really solidified the evidence base. These are not just the recovery study, but other studies of steroids in people with severe COVID. And really, this particular WHO group conglomerated the evidence, and there was a strong signal for benefit, mortality benefit, of the use of steroids in people who, in this instance, had critical illness with COVID-19. Now, what has evolved, of course, though, is not just dexamethasone alone. Here are some data that support the use of remdesivir with dexamethasone and people who are hospitalized with COVID-19. Looking now at a combination of antiviral therapy with remdesivir plus dexamethasone versus dexamethasone alone. Now, this is a retrospective study, so it does have the possibility of unmeasured confounders. But at least the way the evidence here is shaping up, it looks like it favors remdesivir plus dexamethasone in this particular patient population. So I think this is why many of the guidelines have evolved, recommending the combination of an antiviral plus immunomodulator here, dexamethasone. Now, we don't stop just with dexamethasone, though. People will remember in 2021 into 2022 intense studies of what we sometimes called augmented immunomodulation. What we mean by that is taking someone who meets an indication for dexamethasone and considering an additional immunomodulator. And the two classes that got the most attention are the JAK inhibitors with drugs like baricitinib and the IL-6 inhibitors with drugs like tocilizumab. So I want to revisit some of the evidence behind these, what we sometimes call second immunomodulators. So let's start first with baricitinib. As a reminder, is a JAK inhibitor, a Janus kinase inhibitor. Here we're showing two studies, the ACT-2 study funded by the NIH and the recovery study done in the UK. Let's start with ACT-2. ACT-2 looked at baricitinib plus remdesivir versus control. It was in over 1,000 people. What this showed is that there was a reduction or a trend towards a reduction in death when baricitinib was given with remdesivir. And there was also some recovery endpoints. But the point that I want to make here is Act 2 was done at a time where dexamethasone was not yet in widespread use. So really, it's the recovery study that I think informs our decision making mostly around, is the most impactful study around baricitinib, because what this did is it looked at baricitinib plus standard of care, where now standard of care did include steroids. And the important result of recovery for baricitinib is that there was a lower all-cause mortality in the group that got steroids plus baricitinib as compared to the group that just got steroids. And that really changed the game when it came to using baricitinib. Now, the recovery study was supported also by another study called Co-Barrier and Co-Barrier 2. These were double-blind, placebo-controlled, randomized controlled studies. Let's start with Co-Barrier. This was done in people who had elevated inflammatory markers. It was a randomized study of baricitinib versus placebo. In Co-Barrier, about 80% of people were on steroids. The important point about Co-Barrier is the mortality signal. So if you look and zero in on the mortality signal, there was an 8% mortality in the individuals who got baricitinib, mostly with steroids, versus 13% in the group that got placebo. So this was a really substantial reduction in mortality. Co-Barrier 2 was done in an even sicker group of people than in Co-Barrier. In Co-Barrier 2 was done in people on invasive mechanical ventilation or ECMO, so really the sickest of the sick. 86% of them were on steroids. This was a small study compared to Co-Barrier, but here too you see lower mortality in the baricitinib group versus the group that got placebo. And again, majority of people getting steroids. Let's shift gears now from JAK inhibition with baricitinib to tocilizumab. This is an interleukin-6 inhibitor. Here I want to again highlight some data from recovery from the UK, open label randomized study, people hospitalized with COVID, all of whom had severe COVID. They had oxygen saturations less than 92% room air. And in this instance, they had systemic inflammation. And what recovery defined as systemic inflammation is having a CRP of greater than 75 milligrams per liter. And the result here, bottom line here, is that the tocilizumab group did better than the usual care group. And the usual care group, 82% of people were getting steroids. So again, evidence supporting the use of this IL-6 inhibitor. REMAP-CAP was also done around the same time, multinational study with multiple sites involved. And here the comparator was usual care. And what they were looking at were two different IL-6 inhibitors, tocilizumab, the one that we use mostly in the US, and one called sarilumab. And so this was a randomized trial looking at these different interventions. And there was a survival benefit in the group that got the IL-6 inhibitor, tocilizumab, or in this instance, sarilumab, as compared to usual care. The reason why we mostly favor tocilizumab is there are even more data with tocilizumab than there are with sarilumab. If you don't have access to tocilizumab, then sarilumab is a good choice. So I'm going to now bring it back to our faculty, and we're going to take what we've learned in terms of the data for antivirals, remdesivir in particular, as well as these immunomodulators. And maybe I'll start by asking Dr. Patel, how would you take what we know now, and how would you treat this person who has had some immunocompromised, not currently on rituximab or on EPOC chemotherapy, but has pretty rapid progression over the course of 2 days, now on 6 liters and maybe going in the wrong direction? What would you do?
Yeah, there's really good evidence early, as we've talked about, for remdesivir. So I think that's a given. Depending on their oxygenation, steroids, I think are definitely a given. And then one thing that we found helpful is some scores for inflammation. So we use a score called the CHIS2 score, and you can kind of plug in some inflammatory markers, and that can help you decide on the second immunomodulator whether you want to use something like baricitinib. And I think that's kind of how I would think about it in this case.
Dr. Cantrill, you mentioned that you are a big proponent of doing things as quickly as possible rather than waiting till, waiting unnecessarily. How would you engage your colleagues around on this patient? How would you actually implement getting some of these drugs started?
It's really a matter first of deciding what the team wants to do. And then it's the logistics of getting the stuff. If it has to come from pharmacy, and sometimes you have to ride people a little bit. And that's my job. And talk with the nursing staff and just make sure it happens, because time is critical in these folks. And I would really worry about this lady because she shows evidence of going downhill pretty rapidly. And I wonder if she isn't going to end up being intubated in the ED, which I would rather not do. I'd rather use other not less invasive ventilatory techniques, but sometimes that's what's going to happen.
One thing we might want to harken back to is even if this person ended up getting intubated in the ED, this discussion around whether remdesivir suddenly kind of magically loses its potency as soon as you get intubated. And I think biologically it makes sense to me that someone who's early on, as Dr. Patel said, and in this instance who's immunocompromised, where we have good evidence that her own immune system is less likely to be able to contain the virus, that even if she were to be intubated in the emergency department, we're now extrapolating evidence as opposed to having firm evidence. I think I would give the immunomodulator, but start remdesivir, and that would be the rationale. Is we're never going to have, and this is true of all of medicine, we're never going to have every single bit of data that for every single patient. That's where the clinical judgment really comes in.
Yeah, Rush, I agree with that. I mean, especially the history we have is that this has been going on for only 2 days. So her viral replication is probably still quite active. And this is our chance to attenuate that with remdesivir.
So current guidelines would recommend remdesivir and dexamethasone in hospitalized persons like this, and then either baricitinib or tocilizumab. I know we all lived through the kind of the rapid evolution of where we got to now, but maybe I'll ask, what would you most like to know in terms of how we could make our therapies better? What are some of the unknowns that we really, or what are the gaps related to patient care that we really need to fill in the years to come?
Yeah, that's such a good question. And, I feel like we had a brief moment where some of those gaps were filled for a while. We had some preventive therapy for patients who are immune compromised, but those are no longer available. And so I think we've seen so much in the treatment of COVID, and we've seen a lot actually in the trials that we discussed. I think there was some really great early work done, flexibility within our government and internationally that helped us learn a lot when we think about what happened and what has happened. So I think that there's a lot of lessons learned. From the research standpoint, I think the more recent work that has been looking at special populations is still really important, and I think can help us understand, more of these gradations of like trying to understand for this potentially for a BMT patient, is there something that's better than potentially for a solid organ transplant patient? So that's something that I'd be thinking about.
Dr. Cantrill, what do you think the NED physician, clinician in the future really needs to know that they don't know today?
Gosh, I think if we could understand better what factors put these patients at greater risk for decompensation, so I can anticipate where I'm going to have to go with the patient, that to me would be very, very helpful.
Yeah, I will say the recovery studies did us a great favor because they transformed how we treat COVID-19. But of course, the recovery studies were done almost in the cardiology mode where they did tens of thousands of people. And therefore, they didn't and couldn't realistically do the kind of biomarker data that honestly the NIH is particularly good at. So I would love to know, are there biomarkers that could tell me which patients to use a particular immunomodulator in? If I have someone on 1 liter of oxygen, it's not like recovery studied people to that level of detail. And so maybe they should just get remdesivir and just be watched very, very carefully before getting dexamethasone. Now, I don't know that to be true, and I think the default is to give dexamethasone, but maybe we could really refine our understanding of exactly how to intervene. And that's where kind of the translational work coupled with the big clinical trials can make advances. And then the last thing I will say is the immunosuppressed individual. We didn't highlight this, but I'll mention it now. A lot of the data that came from immunomodulatory trials didn't study the most immunocompromised people. And that's where I think we do need either new trials or analyses of observational data to really understand if you're heavily immunosuppressed, should we still have the same approach or should we have a more customized approach? The gradations really matter. So a few additional considerations with immunomodulators. Do avoid or use with very great caution in people who have other infections like bacterial, fungal, or non-SARS-CoV-2 viral infections. In the early days of COVID, we used to worry a lot about co-infections or super-infections with bacterial pathogens. That's not common, but it does occasionally happen. So be careful if they have a bacterial pneumonia on top of their COVID. And then do remember, of course, that prolonged immunomodulatory therapy can lead to reactivation of latent infections, things like hepatitis B, herpes viruses, if they're from the right part of the world. And that includes the U.S., southern U.S., strongyloidiasis, and tuberculosis. Are used with caution in people who are heavily immunosuppressed or at high risk for gastrointestinal perforation. And then just a reminder one more time that people from warm temperate regions should be screened and treated to prevent strongyloiditis, something that's easily prevented with treatment.
Thank you to our faculty, and many thanks to you, our listeners, for joining in. As a reminder, to view the full program, COVID rounds, clinical case discussions on best practices for inpatient COVID-19 management, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.